Thank you, sir, for those kind words. At the onset, I would like to thank Dr. Jaishree ma'am and Dr. Lakshmi ma'am for having given me this opportunity to speak in this excellent webinar. Today's topic of mine is biomarkers and menopause prediction. Justice to this topic. So I will be speaking about the importance of prediction of menopause, the biomarkers, the straw staging, the transition, the hormones involved, the biomarkers involved, the studies, and just summarizing the studies and what to do in the clinic. So by definition, biomarkers are objective, quantifiable characteristics of biological processes. So why do we need to predict menopause? Of course, for those women who wish to delay childbearing and for those who wish to know their ovarian reserve, and for those consultants who want to apply accurate reproductive techniques when the patients are nearing menopause. Also, the age of menopause, when we know that gives an important prediction of the associated health conditions like a lower age, as we all know, is an increased risk for cardiovascular disease and osteoporosis. Whereas an older age at menopause, of course, increased risk for breast cancers, endometrial cancers. And so knowing the age of menopause will definitely make help in making certain interventions for reducing risk earlier in life. So what are the biomarkers that have been studied in prediction of menopause? The most commonly studied, as we all know, and we all most probably use the follicle stimulating hormone, estradiol, and the other things that are studied are Inhibin B, anti-Mullerian hormone, Inhibin A also, and luteal hormones like the progesterones and Inhibin A. So the levels of Inhibin A and Inhibin B and AMH exhibit significant changes in early menopausal transition, during which an apparent decline in fertility already occurs. So what is this AMH? AMH is a glycoprotein. It belongs to the TGF-beta family. Its expression is strongest in the preantral and small antral follicles that are growing and disappears in the subsequent stages of follicle development. The concentration in the serum are not altered by the menstrual cycle. So it's a stable product, very small but growing follicles, reflects the available remaining follicle complement. And what is this Inhibin B? It is produced by the later stage growing follicles, a little bigger follicle, I mean. And inhibins are dimeric polypeptides again. They can be Inhibin A and B. And Inhibin B belongs to TGF-beta family. It's again produced by the antral follicles and it selectively inhibits FSH release. So it reflects reduced follicle cohort size over time. Of course, we all know about the FSH and the antral follicle count. FSH is increased secondary to the ovarian changes. It is to necessitate the folliculogenesis to a higher threshold for the remaining follicles. And antral follicle count, of course, 2 to 9 mm, the size which is a measure of ovarian. So the staging, how is the staging done for the staging as it is done in life? It's done for the reproductive aging also. So the first staging of reproductive aging workshop, the straw, was done in 2001, where the importance was given to the menstrual cycles, the abnormalities in the menstrual cycles, where the early and the late premenopausal transition were divided depending on the menstrual cycle length, and acquired FSH was also included in this straw criteria, where the increase in FSH was found from the late reproductive age to the menopausal transition. So same thing, early transition, what was the menstrual criteria? 7 or more days difference between 2 consecutive cycle lengths. And a late transition, the amenorrhea of at least 60 days was considered. Early postmenopause is up to 5 years after menopause, and the final menstrual period was defined as the last year of final menses, using the data for at least 1 year after this event. So this was again, as it goes on, everything gets revised, and in 2011, the straw plus 10 was introduced, where additional criteria were introduced into this, where the AMH, Inhibin B, and antral follicle count were added on to the straw criteria as a supportive criteria for defining the menopause transition actually. Okay, so what is the straw plus 10? Actually, if you see, the initial things are the same, like the menstrual cycle and the variability, but where the supportive criteria, like the endocrine, has the FSH, of course, is already there. The AMH and Inhibin B have been added to this. And you can see that the changes in the AMH and Inhibin B are starting much earlier, like even in the late reproductive life, and continuing in the menopausal transition group and become almost undetectable at the final menstrual period. Antral follicle count also is similarly showing lower count from early menopausal transition itself. So what is this transition that is happening? The early transition, actually, the follicle loss is compensated by the folliculogenesis rising FSH. Why is this happening? Because of the low AMH and low inhibin B, there is a rising FSH. This is a phase of compensated failure. Whereas in late transition, it is an uncompensated failure, where the follicle loss is not compensated. Okay, and in final stage, the follicle exhaustion becomes complete, where the final menstrual period happens, the FMP. So this is the crux of the whole thing. What is the physiology behind this, to understand the biomarkers that are helping us to stage it? Okay. Initially, the follicle cohort is low. So as we know, the early stage follicles, prenatal follicles, growing follicles are secreting MH to AMH. So the low AMH and there is low inhibin B due to the slower follicle cohort. Okay, but then the high FSH is there because of the increased threshold of these follicles for getting matured and becoming dominant. So the high FSH is maintained again by the low inhibin B, which removes the restraint on the FSH and the surrounding follicles also. So what happens to the follicle? It starts growing very fast under the influence of the increased FSH. And though it doesn't come up to the original follicle size in the reproductive age group, but it because of the aged follicle, it just ovulates even very earlier, at a smaller size than the protein size. And early ovulation happens and it changes into the luteal phase, where the progesterone and inhibin A, which are secreted, are also lower in amount, which fail to again control the high FSH initiation. So as the luteal phase is continuing, there is the high FSH tries to again initiate the follicle growth, which is again not very normal, but a slightly slow, slightly smaller reach ovulation size follicle. So the luteal phase, during the luteal phase of this cycle, the growth of the follicle happens for the next cycle itself. By the start of the menses, there's already a ripe follicle that is there, which might lead to a frequent menstruation that is commonly seen in case of a perimenopausal age group. So what do the studies say? So these studies have started from 1990 for the prediction and prevention of most menopausal characters, and in around 1998 and 2005, first inhibin B was found to be a first endocrine marker of the early transition, where FSH levels were only slightly raised. So the inhibin B, fall in the inhibin B was the first marker. Okay, and then late transition, that is within 3 months of amenorrhea, the marker falls in estrogen and inhibin A, with significant elevations in FSH were observed. So the hallmark endocrine change associated with early changes in menstrual cycle irregularity appears to be a fall in inhibin B and a moderate rise in FSH. So this is another study from Japan, Pradivaki study, which was done in 1,000 perimenopausal ladies, where they have studied on AMH, inhibin B, FSH, and estradiol. And they have found that the standard deviation of serum levels of AMH was considerably lower than that of inhibin B or estrogen, indicating that it is more reliable in terms of the prediction of the onset of menopause. So as we come across the years, AMH has been included in all these studies of biomarkers, and it is found to be an excellent indicator because of its low level, as you see, even before the start of the perimenopausal transition. So you see the lowering of the AMH here, whereas the rest of the things only are coming at the perimenopausal transition age. Of course, there was only qualitative results that were given, and the quantitative results were not been published, were not being recommended because of the studies which were in a lesser number of people. Of course, this is the AMH levels that they have found and how it is decreasing, and it becomes similar at the menopausal transition age and becomes undetectable, almost undetectable at the final menstrual period. So what is the conclusion of this study? AMH is the first hormone reliable to exhibit a change. FSH levels only gradually increase, and there is no decline in estrogen level in case of menopausal transition. Whereas in the late menopausal transition, there is a rapid increase in FSH levels and decline in estrogen levels. This is during the 2 years before and after the menopause. And at this time, the AMH becomes undetectable. So the other big study that has been going on is the SWAN study, which is this study which is done across the nation, and it was done in a large number of population and large recruitments every 5 years. And they have studied the association of the FSH and estradiol, and they have found that high FSH was related to a shorter time to the final menstrual period. And highest estradiol category was associated with an earliest onset of menopause, when associated with the higher FSH. So we have to understand that estradiol does not decrease at the or it might slightly be on the higher side also. So the criteria which shows the graph like the FSH where it is slightly increasing, and estrogen which doesn't decline at the level of the menopausal transition. I mean at the final menstrual period. So just trying to find out if there are any biomarkers for the symptoms. There have been found some associations like high testosterone levels were found to be associated with higher depressive symptoms, and a rapid increase in FSH was associated with difficulty in sleeping, and a rapid decline in estrogen was associated with migraine attacks. And also the increased number of vasomotor symptoms were predictors of earlier final menstrual period, and a higher physical activity and educational status were associated with late final menstrual periods from various studies that have been done. So summarize, anti-Mullerian hormone is the first hormone to exhibit a change in level and is the most reliable marker of ovarian function during menopausal transition. During the early menopausal transition, levels of Inhibin B and AMH present significant changes. FSH only gradually increases, no accompanying decline in the estrogen level. And late menopausal transition stages, the individual differences of AMH decreased and becomes undetectable, and rapid increase in FSH levels. There's a rapid increase here in FSH levels and decline in estrogen levels between 2 years before and after the menstrual cycle. So what do we do in the clinic? Of course, when the patient presents with an irregular menstrual cycle or an oligomenorrhea and asks us regarding her onset of menopause, what do we have to say? Of course, if the woman is over the age of 45 years, the change in menstrual bleeding patterns were a better predictor than going ahead and doing a serum FSH. So you can always say it's okay, you can wait for the menopause. Whereas if it's a woman whose age between 40 to 45 years with an irregular menstrual cycle, we should not be missing to rule out the basic things like the prolactin TSH disorders and of course a Hepzhibha. And of course, under 40 years, we have to go for an evaluation of secondary amenorrhea, and if PMOF is confirmed, a further evaluation is done. Only when in an IVF setup, we might have to go ahead and do these AMF and AMH and Inhibin Bs for applying to the accurate techniques. Thank you.